Hi folks, let's review together the anatomy of the respiratory system. If you remember in the lecture we talked about the upper respiratory tract, the lower respiratory tract, and what defines the lower respiratory tract, as you will see in a little bit, is the larynx. Anything from the larynx and below will be the lower respiratory tract. Anything above the larynx will be the upper respiratory tract. We also talked about the lungs, both the parenchyma, the serous lining that covers the lung, which is the pleura. We'll talk about that. And the process of the pulmonary ventilation, not going into big details of the physiology associated with it, just the anatomical portion of the lungs function. Then we'll talk very briefly about the thoracic wall, innervation of the respiratory system, and a couple of words about the aging of the respiratory system, precisely lung cancer and COPD. Okay, so as I told you earlier, we have the upper respiratory tract, the lower respiratory tract. Upper respiratory tract will be everything all the way till the larynx, and so that will include the nasal cavity, the pharynx, and the lower respiratory tract will have the larynx, the trachea, the bronchi, the bronchioles, and those are the respiratory tracts. That doesn't count the parenchyma of the lung, the tissues of the lung, which is the supportive tissue, the interstitial tissue of the lung, of course. Surrounding the lungs, we will have the pleura, which are the serous lining of the lungs, and you will see in a little bit that we have the visceral and the parietal pleura. So each of those areas we're going to talk briefly about in this online lecture that I am preparing for you to wrap up before our test. And so what functions does the respiratory system do for us? Well, gas conditioning. You would like it to be humid, warm before it gets into your lungs. Gas exchange later on. Sound production, smelling, olfaction, defense, organisms. There is a cough reflex that can be initiated if there is any foreign object that gets in. Also, we have lots of lymphatics associated with the respiratory system, so it also helps with the immune system. For example, the tonsils, the pharyngeal tonsils, and the palatine tonsils, and also the lingual tonsils. So, as we said earlier, we will have the upper and lower respiratory system. There is, of the respiratory system also, we will have what we call conducting system, a conducting system in which there is no exchange of gases, right? So there is no exchange of gases, major exchange, let's put it this way. There is a very minor exchange that happens at the level of the nose, for example, but that's very, very minor. The same kind of respiration or that happens from your skin. You lose some carbon dioxide from your skin, but you're not really breathing. Okay, so we're gonna omit those minor gas leakage, I would say, from the respiratory passage. And the respiratory passage will be the nose, the pharynx, the larynx, the trachea, the main bronchus, right and left bronchus, the bronchial branches, all the way to the respiratory bronchioles. If it's a respiratory bronchiole, then there will be an actual exchange of gases happening there. Otherwise, there isn't much exchange happening. The respiratory portion would be the respiratory bronchioles and the alveoli. So, all the respiratory system is covered with what we call respiratory epithelium, and the respiratory epithelium is pseudostratified columnar epithelium, and it's also ciliated. That means it has cilia on top. In addition to those, you will have a single cell glands. We call them the goblet cells, and they will be secreting quite a bit of mucus secretion. Now, the three areas that you see here, so the mucus layer the pseudostratified cells, which include also the goblet cells and the basement membrane and the connective tissue underlying it, which would be the lamina propria. All of that will be collectively part of your lining, and it's continuous from the nose all the way throughout your respiratory tract. Okay, so remember, the respiratory epithelium is pseudostratified columnar epithelium that is ciliated, and in addition you will have also what we call the goblet cells. Because of the mucus lining and the involvement of the lamina propria, we will call this mucus membrane, or the entire 3 layers here will be called the mucus membrane, in which we add the mucus, in which we add the lamina propria. So we are not just talking about the pseudostratified columnar epithelium that you're seeing here. Okay, so the upper respiratory tract, we agreed anything above the larynx, right? So we will have the nose and the nasal cavities, paranasal sinuses, pharynx, all of that will be part of the upper respiratory. Lower respiratory starts with the larynx, you got it. Okay, so upper respiratory tract, so we start with the nose, the opening of the nose, we call that, you can call it the nostril, you can call it the vestibule, you can call it the anterior nares, which is the term I like. And so we have anterior nares and we have the posterior nares, which is the opening of the nose posteriorly. Another name for the posterior nares is the quana. So we have right and left quana, that will make it quani, that is the plural of it. The nose is primarily lined with the respiratory epithelium, with the exception of the area around the vestibule here, that will be stratified squamous epithelium. And then also we have some hair here that protects against large particles. The mucus lining, of course, will adhere to all the particles that get in, not all, but most of it. Keep in mind that the part here near the cribriform plate of ethmoid is not lined with the respiratory epithelium. That will be where the olfaction is, as we studied in chapter 19. Okay, let's go back to the nose. The nose is associated with cavities. We will talk about those cavities. We call them paranasal sinuses. And we have frontal, ethmoid, sphenoid, and maxillary sinuses. Also, if you remember from talking about the skull, we had shelves in our, or scrolls in our nasal cavity, and those are called conchae. The single is concha. So we have superior concha, middle and inferior conchae. Okay, so all the way towards the end, it will be after the quana, then it will be the nasopharynx, and the nasopharynx will be continuing down into the laryngopharynx or the oropharynx, and from there first the oropharynx and then the laryngopharynx, and from there to the larynx, and we're going to see that together. So we're going to start first with the nose. Primarily the nasal structure is with cartilage, with the exception of the maxillary bone also is here in this area. It's forming part of the bridge of the nose, and then we have the nasal bones, and the frontal bone will be here. The rest, as you can see here, is cartilage. We have lateral cartilages, and we have ala, if you remember ala meaning wings, and so we have major ala, we have minor ala cartilages. Alright, so the nasal cavity begins with what we call the vestibule, or the anterior nares, and then posteriorly will be continuous with the nasopharynx in what we call the quana, or the posterior nares. The nasal septum divides the nasal cavity into right and left. We have mainly cartilage, but also we have, anteriorly we will have cartilage, and then posteriorly we're going to have the vomer is inferior, and the perpendicular plate of ethmoid will be superior, as you remember from studying the skull. We also have the scrolls that I mentioned to you earlier. We have the superior, middle, and inferior nasal conchae, and the conchae will make the turbulence of the air, which is important for the humidification of the air. Also, this kind of turbulence, if you remember from chapter 19, will push the air towards the olfactory epithelium at the roof of the nose. Therefore, the hair cells you have, they are not actual hair, but they are the olfactory cells. They are the ones that will sense that smell. Okay. So the roof of the nasal cavity is made by bones. These are the frontal sphenoid cribriform plate of ethmoid. The floor is made by the palatine process of the maxillary bone or the maxilla, and also by the horizontal plate of the palatine bone. Anteriorly, as we said earlier, will be the vestibules, and another name for it is the anterior nares, and posteriorly we're going to have the quana, and or another name for it will be the posterior nares. Okay, so these are the things we already described. The vestibule or the anterior nares, here is the spelling of the anterior nares if you want the spelling, and here is the quana or the posterior nares or internal nares, that's another third name for it. And these are the conchae, and here is the palatine process of the maxilla and the palatine bone and the roof. All of these things we already described together. So associated with the nose or the nasal cavity is what we call paranasal sinuses, and they all drain into the nasal cavity. And frequently, of course, we get infection in those sinuses or inflammation, and we call that sinusitis. Right? And so we have the frontal sinuses, that's if they are inflamed, that's where you have headache above your eyebrows, and we have the ethmoid sinuses, and if you have headache inflammation in them, you feel headache right between your eyes, and the sphenoid, you kind of feel the pain or the headache almost behind your eyes, and then the maxillary is when they get inflamed, you will feel the pain in your cheek and for the front of your face. So here are the position of them: the frontal sinuses, the maxillary. The maxillary is the largest, and it's also the only one that drains up and then down. That's why sometimes in the beach or after swimming in the pool, if you lay your head a certain way, you will start to have water running from your nose, and that's just because the maxillary sinus got filled. All these sinuses are also filled with respiratory epithelium, which again was the pseudostratified columnar epithelium that is ciliated, and in addition you have the goblet cells to give you the mucus lining. Okay, so the frontal, the ethmoid, the sphenoid towards the back, and then we have the maxillary sinuses here. And so this is just FYI here to show you where those sinuses open. 1, 2, and 3, these are the opening of the ethmoid. So here is ethmoid opening, ethmoid opening, ethmoid opening, right? And this one where the maxillary sinus will be, the sphenoid sinus is opening all the way back here, and the frontal sinus is close to the frontal portion, the front portion of the nose. Okay, so it's just FYI, and of course when you have inflammation of the mucus lining of the nasal cavity, when you have cold or allergy, that will close the openings of the sinuses, and therefore the sinuses will have hard time to drain, hence the headache because of the increased pressure inside your skull. Okay, this is just an x-ray. The idea is to show you here the maxillary sinus, how it's hollow. Your maxilla is hollow when we are taking sideways here x-ray. Okay, so we're good with the nose and the paranasal sinuses, and we got into the pharynx. And the pharynx is divided into 3 portions: nasopharynx, that's the one behind the nose; oropharynx, that's the one behind the mouth; and the laryngopharynx, will be the continuation downward with the larynx. And so the nasopharynx, again, it's continuous with the nasal cavity, and if you remember, the connection between them was the quana, or the posterior nares, and the auditory tube, or the Eustachian tube, opens into the nasopharynx. It also has what we call the pharyngeal tonsil, and we know it by the name adenoid, especially when it gets inflamed, because that will prevent the child from taking air through his nose and will become mouth breather instead. So here we go. Here is the adenoid here. That's the pharyngeal tonsil. And this part here will be your nasopharynx. Okay? Alright, so the important aspect of the nasopharynx is that's the place where the Eustachian tube opens, obviously. Oropharynx, on the other hand, that begins at the end of the soft palate, so its soft palate will be the division here. So anything above that will be the continuous with the nasopharynx, but anything below there will be the oropharynx, right? So this part here will be the oropharynx. Okay. The opening of the oral cavity to the oropharynx is called the fauces, and we're going to study that again in the digestive, or we actually already did in the lecture. And we will have two arches, palatoglossal and the palatopharyngeal arches, and between the two arches we're going to have the palatine tonsils. Also we're going to have another tonsil which is on the tongue, at the base of the tongue. We call that lingual, because of the tongue it's going to be called lingual tonsils. Why do we have all these tonsils? You may have studied that in the physiology. You would like to have lots of lymphoid tissues around areas where there is a good chance for microbes and foreign bodies to enter to your body. So in order to sample everything that's coming in and give you the appropriate immune response towards any of those invaders. Okay, so here are the palatine arches, the palatoglossus and the palatopharyngeus, and we're going to talk about them again, but like I said, over here between the two, that's where the palatine tonsils will be lying. Okay, the laryngopharynx, on the other hand, so we did talk about the nasopharynx, and then the oropharynx, which is this part, and then over here now will be the laryngopharynx, which will be behind the larynx, and then it will be continuous with the larynx, as you will see in just a little bit. Okay. It's also double passage, by the way. The laryngopharynx can be also a continuation towards the esophagus, and what diverts the food or the air is some cartilage here we're going to study together. It's called the epiglottis, and the epiglottis, if it closes the larynx, then the food would rather be diverted towards the esophagus, and if it's open, then the air will be diverted towards the larynx. And some of you will say, well, why can't the air go to the esophagus instead of going to the trachea or the larynx? Well, because of the esophagus, if it's a muscular structure, so it's not open all the time, right? And so it's actually collapsed unless there is food passing through it. And so it's almost impossible for the air, unless you force the air, like swallow air, to get into the esophagus just accidentally. Besides, the negative pressure that you are causing by the diaphragm is the one that is causing the air to go over here, but there is no negative pressure sucking the air into the esophagus, right? And so that's why the air would rather go to the trachea, which is open, and also there is a negative pressure allowing the air to go, rather than just going through the esophagus, which is collapsed, and there is no negative pressure pulling it through. Okay, so we did talk about the three regions, the nasopharynx, the oropharynx, and the laryngopharynx, and then we go from there. You remember the line for the lower respiratory tract starts with the larynx. So this is the first thing we will talk about, the larynx, then we will talk about the trachea, the bronchi, and the bronchioles. We'll start with And then at the very end, we will talk about the respiratory portion. This is the conducting portion in which there is no major exchange of gases happening. The respiratory portion is where the main exchange of gases happen, the respiratory bronchioles and the alveoli. Oh, we're going to study that together. All right, so we're going to start with the larynx, which is the cartilage in front of your neck, as you know. And we have three major single cartilages, right? These are single ones. And we have three. We have three other paired ones. So these are the single, which are three: the thyroid, the cricoid, and the epiglottis. And you will see in a little bit that we also have three paired cartilage as well. Okay, so all right. So the single cartilages we have, the biggest one is the thyroid cartilage, and they're calling it this way because thyro meaning a shield, and it looks like a big shield here. This is from the front. And the laryngeal prominence is the junction between the two sides, right at the middle. And you may have studied in physiology that the cartilage responds to testosterone. That's why the larynx undergoes enlargement during and after puberty in male, and that causes the deepening of the voice and whatnot. Okay, so this is the first one. It's not continuous. The thyroid cartilage is not continuous backwards. It's actually open to posteriorly here. So this is the posterior view, and you will see that the thyroid is not continuous backwards. Whereas if you look at the cricoid meaning ring-like, and so the cricoid is the only one that is continuous. And so anteriorly it's kind of like not really high, but posteriorly it's way higher, right? But it's continuous. You can see here in a section, it will show a mid-sagittal section here. It shows the how high it is anteriorly compared to posteriorly. So this is the cricoid. A third one of the single cartilages we have is the epiglottis. And the epiglottis, you can see the tip of it here, and posteriorly it looks like that. If we take a sagittal section, you can see the epiglottis is like a spoon-shaped cartilage here, and it plays a very important function. Every time you are swallowing, you are lifting the larynx up, and as you are lifting the larynx up, the epiglottis will shut it down and therefore will prevent the passage of the food into the larynx. Okay, these are the single cartilages, and the biggest, of course, is the thyroid, as we already described. And in addition to those, we're going to have paired cartilages. You can see them here. We have the corniculate and the arytenoid, and we have also something called cuneiform, which we can see in this particular. Here we go. This is the cuneiform. And the larynx, before we skip through this slide, we have ligaments, of course, connecting the larynx to structures. And so connecting the thyroid cartilage to the hyoid bone, and that will be the thyrohyoid ligament or the thyrohyoid membrane. We also have the cricothyroid ligament, which is between the cricoid and the thyroid cartilage. Why are they important? Because you can put endotracheal tube into those membranes, and therefore can assist in the respiration in case of emergency, or if you a person who can't breathe on his own and you want to put a tube in there. Okay. All right. So the thyroid, as I said earlier, it's the largest. It has anterior and lateral wall, but there is no posterior wall. And there is the laryngeal prominence, and sometimes we refer to as the Adam's apple in male especially, and it usually is larger in male, and that's because of the effect of testosterone. Okay. The cricoid cartilage is the only one that is complete ring, right? And it's immediately inferior to it, and we have here the cricothyroid ligament or the cricothyroid membrane that connects the two together, or tie the two together. The epiglottis, on the other hand, we're going to study that together in just a little bit. And the idea of the epiglottis is it functions to prevent the passage of food and drinks into the larynx. How does that happen? When you swallow, if you notice, you're lifting the entire larynx up, and then it will come into contact with the epiglottis and therefore shutting it down and preventing the passage of the food to your larynx. Okay, epiglottis, like I said, it's spoon-shaped cartilage, and during swallowing, you're lifting the larynx and therefore you are closing it. So here we go. This is just an example of a swallowing process. And so when you start to swallow, you're lifting up your larynx. As you lift up the larynx, it will come in contact with the epiglottis. Therefore, the food will be diverted into the esophagus behind the larynx and behind the trachea. This is just a video here that I placed for you, which shows you the swallowing process. So we're going to just skip through that. The minor cartilages, which are very important in the sound production, and I mean the arytenoid and the corniculate, but not necessarily the cuneiform, and you will see them in the next slide here. So here we go. The arytenoid, because it's shaped like a ladle, the big spoon that you serve food with or soup with, as you can see here, the shape of it. And then we have the corniculate, which looks like a little corn, and the cuneiform, you don't see it here, but it's actually over here, which is not associated with these two the cuneiform. It's just covered with mucous membrane. So the arytenoid is connected at the tip of it to the vocal ligaments, and you will see we have two muscles, the lateral cricoarytenoid and the anterior cricoarytenoid, and those can shift the arytenoid, switch the arytenoid to open and close, and you can see the opening and closing movement here, bringing the two ligaments together. And don't think that there will be air passing over here in this wide area, because in real life those are blocked by a fold. We call that a vocal fold, or the vestibular fold, which is not a true vocal cord. It's a fake or false vocal cord. This is the vocal cord, which is covered now by mucus lining. The opening between the cords is called the rima glottis, and if you add the folds to it, the cords to it, then together that will be called the glottis. So the glottis is not just the opening, the glottis is the opening plus the vocal folds on top, in addition to it. Sounds good? But the opening itself is the rima glottis. Okay, so as I told you, we have a couple of muscles here, the posterior and the lateral cricoarytenoid, and the posterior cricoarytenoid will bring the arytenoid cartilages this way, and therefore it will allow the vocal cords to be separated from each other, whereas the lateral ones, if they contract, then you will turn the arytenoid this direction medially, and the tip of the arytenoid will go medially, and therefore that will tense the vocal cords and will close the rima glottis. So here is the rima glottis being open, and here is the rima glottis being closed. Okay. So the vocal folds are made by vocal ligaments, and on top of them, covering them, will be mucous membrane. The opening between the vocal cords, as we said, or vocal folds, is the rima glottis, and if you add the vocal folds plus the rima glottis, that's what we call the glottis. And if you remember the cartilage that was shaped like a spoon, if you remember, we call that epiglottis, right? And so I'm going to skip through the videos because that's available for you on Canvas, and we'll just go straight into, from the larynx, we will go into the trachea. We're good with the cartilages of the larynx. The thyroid, the cricoid, the epiglottis, these are the single cartilages, and then we have the paired cartilages, the arytenoid, the corniculate, and we have the cuneiform, right? And please remember that the muscle attaches between the cricoid cartilage and the arytenoid, right? We have the lateral and the posterior cricoarytenoid, and if you remember from the picture also, the vocal cords or the vocal ligaments are attached from the tip of the arytenoid all the way to the thyroid, which makes sense because that is your vocal box. If you have an instrument, a musical instrument, you would like the cords to be attached to the most hollow structure, and that will be the thyroid to give you the resonance, of course, right? Okay. Getting to the trachea. Trachea is approximately 13 centimeters in length, and it's supported by C-shaped tracheal cartilages. They are open from behind, posteriorly, they are not continuous, and there is a muscle that links the two ends of the C together, and we call that trachealis muscle, and you will see that in just a little bit. So if we take a section in the trachea, you will see the tracheal ring here. This is anteriorly, right? And this is posteriorly, and posteriorly we're going to have what we call trachealis muscle. What's covering the trachea? You know it. It is the respiratory epithelium, right? And the respiratory epithelium is the pseudostratified columnar epithelium with ciliated, and also it has the goblet cells in between them. And we agreed that the whole thing will be the mucous membrane, which will be a layer of mucus, the epithelium, and the lamina propria. All of that together will be called the mucous membrane. So we did talk about the trachealis and the lining of the trachea. This is just a scanning electron microscopy picture of the pseudostratified columnar epithelium to show you the cilia in it, and the cilia beat all the time upwards in order to push all the mucus to the oral cavity, and then by swallowing that mucus into the stomach, then it will be digested by the enzymes and the acidity of the stomach. Okay. From the bronchus, from the trachea will split into right and left. At the point of splitting, that will be a continuous cartilage, and then it will split into right and left bronchus. We can see that here. This cartilage here is called carina, and which is this. It's a cartilage that almost like a V-shaped cartilage before you get into the right and the left bronchus. Pretty much the same lining and the same structure of the right and the left bronchus, but the right and left bronchus now are complete rings, not C-shaped rings, because we needed the C-shaped rings here in the trachea, because behind it I had the esophagus, and I want space to allow the esophagus to expand when you're eating, whereas that's why you choke if the food stays in the esophagus, because it will push against that empty posterior or non-supported posterior wall of the trachea, and therefore you feel like choking or unable to take your breath. Okay, but the bronchus, right and left bronchus, they are complete rings, and so are the bronchial branches, all the way till you start to get into the bronchioles. You're going to start to have deterioration of that cartilage lining, and the bronchioles, the terminal bronchioles here, will have only muscles, smooth muscles that make the walls, but no cartilage, and we'll talk about that in just a little bit. Something I want you to notice here is that the right bronchus is wider than the left bronchus, and the right bronchus is also more vertical than the left bronchus. Why is that important? Well, because of foreign objects, if they get inhaled, especially by little kids, if you are in upright position, then there is more chance for that foreign object to end in the right lung rather than the left lung, just because how the bronchus, the main right bronchus, is different than the left bronchus. Okay. So the primary bronchus will split into giving you secondary bronchi. Secondary bronchi will give you 8 to 10 tertiary bronchi, and keep branching and branching and branching, and that's what we call bronchial trees. At the very end, at the bronchioles, you're not going to have any cartilage. Instead, it is lined with muscles, smooth muscles, but no cartilage. Also, the epithelium will change. In the terminal bronchioles, you're not going to have the pseudostratified columnar epithelium, but you will have simple squamous, and that will allow the exchange of gases at what we call the respiratory bronchioles, right? Because now the epithelium got thin enough, and if you have enough capillaries surrounding it, then there will be some exchange of gases, although of course most of the exchanges will happen at the alveoli. Okay, so the bronchioles are less than 1 millimeter, and they don't have cartilage. Instead, they have smooth muscle lining, and the relaxation of the smooth muscles, which is sympathetic innervation of the bronchioles, will cause bronchodilation. A lot of things can cause bronchioloconstriction. Parasympathetic, also histamine and other irritants, can cause bronchioloconstriction. The respiratory portion of the respiratory system, that's where significant amount of gases can be exchanged, and that happens at the respiratory bronchioles and alveolar ducts, but primarily at the alveoli. And we can see the alveoli here, so essentially like grapes connected to each other to a single stem, and that will be the respiratory bronchiole. If the wall is thin enough to allow some exchanges here happening, then we call it respiratory bronchiole. But like I said, the main really exchange of gases happening at the alveoli, of course. Okay, we'll talk about the structure of the alveoli in a bit. The alveoli are very thin-walled, which is great because the gas will be here and the capillaries are outside, and you would like the space to be minimal to allow the gases to go in and out through the walls, right? And in order to equalize the pressure, we will have pores. We call them alveolar pores or pores of Kohn, and those are to normalize the pressure across the alveoli so they're expanded almost at the same force. Okay. All right. This is just a section here through the alveoli, showing you how the structure looks like, which is very hard to make, but maybe with a scanning electron microscopy you can see better the walls of the alveoli, as you can see in this picture. Okay, so the alveolus is covered by lining cells, and the major lining is what we call type 1 alveolar cells. These are squamous flat cells, and that's where the exchange of gases primarily happens in your system. Alveolar type 2 cells or type 2 alveolar cells, their function is to secrete surfactant. So these are type 1 alveolar cells, and these are type 2. Type 2 does not really permit exchange of gases, but their function is to secrete surfactant, which is very important to prevent the collapse of your lungs. There is a third cell, and in the old books they used to call it a third or type 3 alveolar cells, which are actually mobile macrophages. They are like duster cells. They go back and forth over the alveoli in order to clean it. All right. The respiratory membrane is a combination of three things. So the respiratory membrane will be the wall of the capillary, the wall of the alveolus, and the interstitial space in between, right? That's the respiratory membrane. So we will have the alveolar epithelium, we'll have the interstitial space, and we're going to have our interstitial tissue, and we will have the capillary endothelium, right? That's what we call respiratory membrane. Okay. We did talk about the alveolar macrophages, which are mobile. It's not sit in place, and the function is to clean up your alveoli from any small particles or debris. The lungs are surrounded by what we call pleura, that is the serous lining of the lungs, and we will have between the two layers of the pleura, we will have a potential space known as the pleural cavity, and the pleura itself has a layer which is adherent to the lung, very tightly adherent to the lung. You can't peel it off, and we call that the visceral. Anytime we have something close to the organ, we call it visceral. Anytime we have another layer further away from that, we'll call it a parietal, right? So sort of like the pericardium, we had the visceral pericardium, parietal pericardium. We also, in the digestive system, we studied together that we have the visceral peritoneum and the parietal peritoneum. Here we have the visceral pleura and the parietal pleura, and the space between them will be the pleural cavity. There isn't much fluid in here. You shouldn't have much fluid, but you will have maybe a couple of mLs here in this recess. And of course, when there is inflammation of the pleura, then there will be pleurisy, or also can be any blood or pus accumulating in that cavity, and that of course can lead to some serious complications. But we get the pleural lining and the two layers. The parietal pleura is very adherent. Remember how I told you that the visceral pleura is very adherent to the lungs? The parietal pleura is very adherent to the chest cage, and inferiorly here it will be very adherent to the diaphragm. Okay, so here is an image of pleurisy, and you can see here that it became so opaque that the fluid here, probably pus or blood, has been accumulating and giving this radio-dense image that you can see here in that X-ray. Okay, the lungs itself are conical in shape. The right is bigger than the left, and you will see, because of course then the left we will have the heart, we'll have the apex, which is the tip, the base, and we have surfaces. The surface against the chest wall, we'll call that the costal surface, and we'll have the mediastinal surface that's facing medially, but we also have the base which is facing the diaphragm. So if we look here, you will see that this is the apex, this is the base, this is what we call the costal surface, which is the surface facing the chest wall. There is also vertebral surface, which is this area here, because it will be there will be indentation here from the vertebrae posteriorly. But anyhow, so we will have the right and the left. The right will have three lobes. Will have the upper, middle, and the inferior, whereas the left will have only the upper and the lower. And the left will have a tiny little tongue here, which we refer to as the lingula. This piece here, which is a notch, this indentation here, that is called the cardiac notch of the left lung. So in the medial surface, or the mediastinal surface, we are going to have a groove here where the blood vessels are, and we call that the hilum. And within that hilum, we will have the root of the lung, and the root of the lung are all those blood vessels and the right and left bronchus getting into the lung or out of the lung, and we call that the root of the lung, which will be in the hilum, right? The hilum is this groove that you see in the medial surface. Okay, so that concave depression is the hilum. Within the hilum, you will have the structures which will be the pulmonary artery, the pulmonary veins, the bronchi, the lymphatic drainage, the bronchial artery, the bronchial vein. All of these things are passing through the hilum, and collectively we call all of these things the root of the lung. Okay, so we agreed that the left lung is relatively smaller, has only two lobes, has single fissure, which is oblique fissure. It doesn't have the third lobe that we saw, the middle lobe that we saw in the right lung, but it has this little tongue, which is the lingula, and we will have, of course, the cardiac notch, as I told you earlier. So here's the cardiac notch, and here is the lingula. This is the base, which will be facing the diaphragm, of course. Okay, the right lung, on the other hand, will have the oblique and horizontal fissures, which will give you the superior, middle, and inferior lobes. Interestingly, as the branches of the bronchus, as the bronchial branches are dividing further and further, they're accompanying with their own blood supply, and so it's becoming almost autonomous, sort of like the states here in the US, that they have their self-rule, and so you can remove that segment from the lobe without affecting the function of them, because this segment is receiving blood branches that are different than this, and they're receiving bronchial branches that are different than this, right? So we call that the bronchopulmonary segments, which is very important if you are removing a lesion like cancer or sarcoid from the lung, because that part is independent, right? So you can, if you know that the tumor hasn't spread, you can cut that part, and the rest of the lung will have just normal, semi-normal function. Two blood supply going in and out from the lung. There will be the pulmonary circulation coming through the pulmonary artery and draining by the pulmonary vein. Keep in mind, of course, that the pulmonary artery is bringing unoxygenated blood, so we need some oxygenated blood, and that will be bronchial branches of the aorta, and it's coming also through the root in the hilum area and bronchial artery and draining by bronchial vein. So the lungs are not only receiving venous blood, but they're also receiving arterial blood, right? Is heavy lymphatic drainage of the lung. We don't have to know where they are, where they lie, but the importance of the lymphatic drainage is making the lungs or the lung cancer very susceptible for metastasis because of the heavy lymphatics associated with it, right? But why do we have that many lymph nodes? Because if you think of all the foreign objects that come through your lungs, you would like to put lots of lymphatic tissue nearby to sample all of these things, because you remember the macrophages will take those particles and go to the lymph nodes and to inform the lymph nodes what's going on. Also, all the debris is going to drain into the lymphatics, and therefore you build your immune system, stimulate the T and the B lymphocytes, if you remember from immunology and physiology, and therefore you're building your immune system. So it's not intentionally made that it spreads cancer, but the cancer spreads because they are there, right? Because it's just the function of those lymph nodes are very important, but unfortunately that's also the route cancer can easily use to spread. And it makes a lot of difference. We're not going to go into the clinical aspect of it, but it makes a lot of difference which lymph nodes are involved, and that changes the stage of the disease of lung cancer. Okay, this is part of the physiology, so I'm going to skip through this slide. The movements during respiration, again, that's physiology. We have what we call lateral and vertical and anterior posterior movements. So vertical movement, that means the diaphragm goes up and down. Lateral, your chest wall is expanding laterally, and those will be muscles attached to the ribs, and we have what we call accessory respiratory muscles, and these will be also respiratory muscle. Anterior and posterior movements are also muscles attached to the ribs, like the serratus posterior superior, serratus posterior inferior, even the pectoralis major. All of these muscles can help in the respiration by pulling the ribs and expanding your chest cavity, not only using the diaphragm. The only time we use only the diaphragm is in little babies, because they don't have strong skeletal muscles yet, so the diaphragm becomes the main respiratory muscle, and we call that abdominal respiration. And if you look at little babies when they breathe, you see their belly goes, bigger and smaller, bigger and smaller, and that's called abdominal respiration, which we can also see if someone has a fracture in a rib and tries not to move the chest wall much. So you'll see the person breathing more with what we call abdominal respiration, so using the diaphragm more than the other movements. We don't have to remember those muscles now because we went over them when we talked about the skeletal muscles, but just as a reminder for you, we have the scalenes, external, internal, intercostal, the transverse thoracic, serratus posterior superior, serratus posterior inferior, but we have many more than that. Even we have the abdominal muscles. They can also compress the chest wall, like the rectus abdominis. We have the serratus anterior, can assist a little bit in the respiration. We have even the sternocleidomastoid, can assist in the respiration. We have a lot of muscles can help you in the process of deep respiration. Okay, so I'm going to skip through a couple of slides here. These are the muscles that we covered together when we talked about the skeletal, the musculoskeletal system, and so there is no reason for us to go over that again. The innervation, we have sympathetic and parasympathetic. Innervation, parasympathetic through the vagus, and sympathetic we will have some pulmonary plexus, which is like web-like network of nerve fibers that go through the hilum and will spread all over the lungs. But remember that the respiratory, the lungs are, you're breathing all the time whether you're awake or not, which tells you that there is a rhythm. Yes, you can override that rhythm, but there is an automated rhythm that continues whether you're asleep or not. So it's not really associated with the cerebral cortex, because the cerebral cortex doesn't function very well when you are asleep, but it's associated with the brain stem. So in the medulla oblongata, we're going to have what we call the dorsal and ventral respiratory group, and the dorsal will be associated with inspiration, the ventral will be associated with expiration or exhalation, and then in addition to that, we're going to have what we call the apneustic and the pneumotaxic centers. These are in the pons, and these will smooth your respiratory rhythm for you and creates not abrupt inhalation and exhalation, but rather smooth one. There is also Pitzinger center here, but we don't have to remember that either. Okay, so we agreed that those two centers, the apneustic and the pneumotaxic centers, they smooth the respiratory movements for you. Collectively, those centers, whether in the medulla oblongata or the pons, the function is to provide you a rhythm, a very smooth rhythm, and whether you're awake or not, the rhythm continues. Okay, so in addition, we have other input, like there is coughing reflex. You can also, the cerebral cortex can override that rhythm. You can hold your breathing. You can take a deep breath when you don't have to take a deep breath. So there is, of course, some voluntary involvement in the respiratory movements, but this overriding of the rhythm doesn't last forever. With age, there will be some destruction in the parenchyma, and that, of course, with exposure to pollutants, mainly tobacco and other industrial smoke or whatnot, that will cause damage in the parenchyma, which can lead to COPD, can lead to emphysema, and in some cases also can increase the risk of cancer. We're not going over details of that since it's not pathology or pathophysiology, but just important to realize, of course, that with age comes some problems with the lung tissue, and it's not only limited to COPD or emphysema or lung cancer. So just a small word here about that aspect of the disease, but without going into the types and small cell lung cancer, non-small cell lung cancer, and the different types of non-small cell lung cancer. We don't have to go over that. But however, this was a wrap of our anatomy of the respiratory system. I hope that this will help you during reviewing the material for your exam, and I will try to make an additional one also for the cardiovascular system, and so hopefully you will find that helpful. See you later.